Good morning, everyone, and welcome to our statewide Reentry Council Collaborative, the last one for the year. Happy Thanksgiving to everybody, and we sure do have a lot to be thankful for here in North Carolina. I think we have a great agenda for everybody today. We will be speaking about peer support specialists, new training that the Department of Health and Human Services is going to put out. And also, we will hear from Dr. Wheeler on our updates of peer support specialists that are in our incarcerated population. Finally, we will have Dr. Campbell, our Chief Medical Officer, report out on our MOUD program within our facilities. So excited to have everybody on today. And as I said, there's a lot to be thankful for in North Carolina, especially with all that we're doing with reentry. So I hope you enjoy this today. And I want to check with Secretary Dismukes, who is on with us. Is there any comments you would like to make before we get started?
Thanks, George. I'm glad to be here with everybody today. Thank you all for joining us on this holiday week. I think that we've got some great information, and so we were glad to share with everybody and hope everybody has a great and happy Thanksgiving.
Thank you, Secretary. We appreciate it. Letitia, any comments from you before I start? She is our chairperson for the statewide Reentry Council Collaborative.
Good morning, everyone. Thank you for joining for our fourth quarter SRCC quarterly meeting. At the top of the agenda is our ethics statement. I do ask you to read that silently, just to make sure that we are in accordance with what we're doing with this public meeting. And at this time, we're going to go ahead with the rest of the agenda. And I see that we have Senior Deputy Secretary Pettigrew will be coming back to give us a Reentry 2030 updates at this time. Thank you.
Thank you, Director Thrash. Appreciate that. Yes, we have some exciting updates for our Reentry 2030 in North Carolina. Again, we are thankful for all that's going on with the Reentry 2030. As a reminder, this was from Executive Order 303 from Governor Cooper, who in it ordered us to create a joint reentry council and create a strategic plan to transform reentry by 2030 in a whole of government coordination way. And so we have done that. All the Joint Reentry Council has membership from all the cabinet agencies, including Office of State Budget Management, Office of State Human Resources. We also have a formerly incarcerated representation from Kerwin Pittman with RRES. And so we worked for the first 6 months to build out a strategic plan. And that strategic plan is the most robust, the most comprehensive in the country. And just a reminder, there are 6 states that are part of Reentry 2030, and that's in collaboration with Council of State Governments Nonprofit Foundation. We were the 3rd state to join, but I truly believe we are a leader on the national level. We have 4 overarching goals in our strategic plan, 26 objectives, 133 strategies, and 95 metrics. That was completed and submitted to Governor Cooper in August of 2024. And it was done by 6 subcommittees that got together on various topics and had members of all cabinet agencies represented, formerly incarcerated, and from our reentry community are represented on those subcommittees that created the strategic plan. They continue to work to achieve our strategies, objectives, and goals. And we turned in our first progress report on education in October of 2024 and overall strategic plan in December of 2024. Now that time has come around to present it to the governor, and we are doing that with the education report, and we will be presenting the progress report in December of 2025. The other thing we are excited about, and it is the first in the country, is Governor Stein is very much supportive of our Reentry 2030 efforts. In fact, his wife, First Lady Anna Stein, has joined as a Joint Reentry Council member this year. Also, we are the first state to have a public-facing data dashboard that shares what Reentry 2030 strategic plan, where our metrics are, where we are on our strategies. It's there for everybody to see. It's public-facing. You can find it. The best way to find it is to Google NC Reentry 2030, and that will share all that we have, the progress report, the dashboard. You can see it all there. So that was launched in September of 2025, and we're very proud of that. Now we have completed the education report that was due this year, and we are excited to share with everybody. We have seen an increase in education programming engagement by our incarcerated population and completions. So we are making a lot of progress. Last year, when we submitted it, we had over 50 strategies either completed or in progress. This year, we are over 60, close to 70, if not over 70, and we will have that in the progress report in December for everybody to see. So we're excited about all that's going on. Again, Reentry 2030 is about transforming through a whole government coordination by 2030. So if y'all are counting, we're down to 4 years. So we are really going to hit the gas in 2026 and get a lot done. The other thing that I wanted to highlight with Reentry 2030 is with our collaboration with the Council of State Governments. They completed a housing assessment for the state of North Carolina to really help us achieve our goals in our housing part of Reentry 2030. It's probably one of the most ambitious and most difficult projects in Reentry 2030, but we have good partnerships there. We're also, through our reorganization of the Department of Adult Correction, we are adding a housing programs director that is going to be tasked with moving those strategies forward with that housing subcommittee. So we're excited about getting that person on, whoever that will be, and building out those alternatives strategies to help our individuals reenter the community to have stable housing. So please join us at our public meetings with the Joint Reentry Council. We do them every couple of months. The next one will be, and Guy, correct me if I'm wrong, January 12th, I think it is, at the Aldix Chapel, and Guy will correct me if I'm wrong. We are also streaming those as well from now on. The last one we did was a couple weeks ago out west in Spruce Pine at Mayland Community College. We had a great panel of formerly incarcerated and one incarcerated person, and two of our on the boots ground people who work with our local reentry councils in the mountains, Buncombe County, Avery, Yancey, Mitchell, and McDowell and their LRCs. And our Secretary Dismukes moderated that panel. It has been recorded and will be posted on the YouTube, on North NCDAC's YouTube account. You'll be able to view that and see it in its entirety. We're very proud of it. It was a great meeting, great discussion, and a lot of engagement, and our largest crowd that we've ever had attend that meeting. Guy, did I get incorrect on the date?
Good morning, everybody. So you were close, sir, but the meeting will actually be January 7th at Dick's Chapel. So January 7th. And if you did not get a calendar invite, please let me know, Guy Buckner at dac.nc.gov, and I will definitely get you that calendar invite for the meeting.
So Guy keeps me straight. Thank Guy for everything. He helps us run these meetings and the JRC meetings, so we really appreciate it. So that is the update on the Reentry 2030 effort. I think we're going to have great information in the future and great news in 2026 about that initiative, and we are confident we are going to accomplish all that we have set out in Reentry 2030. So, Letitia, I will turn it back over to you.
Thank you, George, for those updates, and everyone, hopefully you took note of the updates for our Reentry 2030 strategic planning. We're doing a lot of great work with that, and North Carolina is leading the way in what we do with reentry, and we're very grateful under the leadership of Secretary Dismukes. At this time, we do have our presentations, as Senior Deputy Secretary mentioned. We will be highlighting substance use treatment programming and what we do in our institutions and what we're doing in the local community across the state. So at this time, we will have Dr. Arthur Campbell, who is Adult Correction Chief Medical Officer, and he will be presenting on what we're actually doing in our institutions with the MOUD program. So Dr. Campbell, I will turn it over to you for you to present at this time.
Okay, good morning, everyone. First of all, I want to thank everyone for joining today. And I really echo others' comments, sincere best wishes everyone for a safe and enjoyable Thanksgiving holiday. And as we prepare to update everyone on MOUD in the spirit of the holiday, I really want to thank our entire MOUD team and really our entire health services team, really for the monumental effort in establishing and expanding medication for opioid use disorder within our agency. On the call with us is Ms. Taisha Young. She is the program manager for the MOUD program, and sincere appreciation to her for everything she does. So with that, I'm going to go ahead and get started. Next slide, please. Okay, so if I'd like to take just a moment to really go through some of the program history for folks that aren't aware, kind of how we got to where we are today. I think it's important to understand that. So we initiated the MOUD program, called it MAT at the time, and that was a partnership with NC Fit and with UNC Mayhec, and we did that through some grant funding beginning in 2021. We started that at 2 facilities focusing on reentry MOUD, and that was at Orange Correctional Center for our males and CCIW for our females. That funding was exhausted in June of 2024, and we as a department assumed sole responsibility for the program since that time. A little bit about the structure of the program. It consists of a medical director, a clinical director, regional MOUD practitioners, program manager, and just a couple nursing staff at this point. It is a regional program. For folks that aren't aware, we have 4 regions within the prison, and we have 1 MOUD practitioner for each region, including a newly hired fellowship-trained addiction medicine physician. We're really happy to be able to bring her on board. Since that time, we've done some very significant expansion. We first of all expanded to include all custody levels. And now we have a total of 24 institutions, including all of our female facilities and 20 male facilities, including both of our confinement and response to violations facilities. I would like to note that currently there's been no allocated to DAC for implementation of this program. However, because we realize how important this program is, we continue to push forward. Next slide, please. So as we look to develop the program, we really had, given the fact that we had limited or no resources, we really had to figure out where we're going to prioritize our efforts. And inarguably, the most critical need is where we needed to focus. And that's going to be on individuals that are re-entering from custody, where there's up to a 40 to 50 times increased risk of overdose deaths in those first weeks after their re-entry. So obviously that was our initial priority of effort, and that continues to be our priority effort at this point. I would like to note that the other consideration we made is that in custody deaths within our agency from illicit drug overdoses are low. And of those, opioids are still not the leading cause. The last opiate-related death within our custody was 21 months ago. That was in February of 2024. We have had 6 OCME confirmed deaths from illicit drug overdoses this year. 5 of those were attributed to synthetic cannabinoids, and 1 was methamphetamine. So once we determine where we're going to prioritize our efforts in establishing the program, we really had to select the medication we're going to use. And there were several factors that we used to make that determination. First and foremost, safety and security was our overarching concern, primarily to minimize diversion. And in doing so, not only protect the safety and security of those in our custody, but also our staff, but also to help get buy-in from staff regarding the program. So the second consideration was the fact that, we do continue to operate with a really significant nursing vacancy rate within our agency. We had to determine a way to deliver this program with the least demand on our staff that we could have. The final thing was we wanted to try to do everything we could. This, again, getting back to that critical need. How can we provide the most protection to individuals in elite custody? And we determined that the best way to do all of those things was going to be using a long-acting buprenorphine medication. We initially began with Sublocade. We've now transitioned to Brixadi, and that continues our preferred treatment option. Next slide. So just briefly, I'll talk about the four programs we have in place for MOUD. We have a very long-standing maternity MOUD program in place for more than a decade now. That program is administered by the UNC obstetricians who provide care for our pregnant patients in our custody. We have a sustained or maintenance MOUD treatment program. So currently that's for individuals that arrive to our custody on active MOUD treatment, either from the community and county jails and detention centers who have sentences less than 90 days. And the biggest program, of course, our main effort is the Reentry MOUD program. And 45 to 60 days prior to release, we start actively screening and accepting referrals for the program. The proactive screening looks at several criteria. You can see some of those listed here. There are other ones we use as well. And then we also have referrals. Those can come from either medical or mental health practitioners, from correctional case managers, and there can also be self-referrals from the patients themselves. The next step in that is their screening by the MOUD practitioner, and if they meet criteria, then they're enrolled in the program. Subsequently, they go through an induction period with sublingual administered tablets, followed by an injection 3 to 5 days prior to release. Critically important in this is the continuity of care in the community. We have a very long-standing and growing relationship with NC-FIT, the formerly incarcerated transition, and we continue to partner with them to try to establish continuity of care within the community. We have also begun providing Narcan to folks that are leaving our custody. Initially, we started providing that medication to just people that were in the MOUD program, but have recently expanded to include all individuals released from our custody, and regardless of whether in the program or not. Next slide. So this is a map currently. This is a map provided by NC-FIT, and you can see that they have increasingly significant coverage for counties across North Carolina. Some of them are, direct coverage for within that county, and many of them cover surrounding counties. And you can tell by looking at that kind of what that coverage is. It's about 66 counties currently within North Carolina that NC-FIT has coverage for. And you can see some of the various partnerships they have. They are utilizing all kinds of resources, whether they're local OTPs, whether they're federally qualified health centers, and they also, rely on both mobile and virtual services to provide the treatment for these patients when they leave. Next slide. So I thought I'd just provide an update on kind of what we've been able to do so far since we started the program. And the first consideration was the intake. So there are roughly half the counties in North Carolina right now. The jails or detention centers are providing some sort of MOUD treatment. Some of those individuals subsequently end up in our custody, and we need to assume their care. So far since we started tracking this in 2023, there's been about 760 cases that were transferred to our custody on treatment. And you can see those numbers. They've remained fairly steady. We actually anticipated there would be an increase, but they've remained relatively constant. And you can see to the right, the counties, the top counties as far as, counties that are most active in the MOUD program that are sending folks to our custody. And then on the other side of that are the releases. So we have thus far released 1,100 individuals on active MOUD treatment over the past 12 months. And they've released 88 counties in North Carolina and as well as 11 other states. Interestingly, if you look at the graph, we continue to have a very high proportion of folks that are enrolled in the program are our female patients. You can see that NCCIW, Anson Correctional, and Western Correctional Center for Women occupy about 60% of the individuals that are being enrolled in the program currently, as opposed to a lot of the male facilities. We do see that there is starting to be some reversal of that, and we're starting to an increased number of males in our custody that are being enrolled in the program. So we're going to continue to follow that data pretty closely. To the right, you can see the counties where these top 20 counties where we've released individuals that are on active MOUD treatment. Again, for a total of 88 counties so far. And to date, we have provided just shy of 14,000 doses of Narcan to individuals releasing from our custody. Next slide. Okay, so finally, where are we going? It is our intent to expand Reentry MOUD to every one of our institutions. Currently, we've put that on hold for several factors, primarily the fact that we're under a continuing resolution and we're uncertain of future funding. But the next goals are going to be initiate maintenance MOUD program at both of our residential ACDP facilities, that's Start Center and Black Mountain. What that's going to allow us to do is increase the number of individuals that can be enrolled in those programs. And I think it'll have a pretty tremendous impact to the community. We also want to be able to sustain provision of Narcan to all releasing individuals from our custody. Again, that's going to be subject to funding. And as I discussed, I want to expand Reentry MOUD to every single institution across the state. And then the next thing we're going to start looking at is expanding maintenance MOUD. So like I mentioned earlier, we're currently providing that maintenance or sustained treatment for individuals that have a 90-day sentence or less. We want to start expanding that timeline further into their sentence. And then there are lots of future goals ahead. So we've got to look at things such as expansion of medication treatment options and various other things that we'll continue to look at based on our capabilities and funding for the program. And I'd like to take just a moment more broadly to talk about some of the things that I think are critically important. The continuity of care in the community is by far one of the most important parts of this program. And NCFIT are incredible partners, but they are incredibly challenged. And I think that one of the things that we need to try to do collectively is try to get additional funding for that program and other similar programs so that we can establish pretty secure continuity of care for folks when they leave. Then I think the biggest lift is going to be doing some research for individuals that are releasing from custody that are on treatment. There's a lot of research on folks in the community that are not on treatment, but I think where we're lacking is the program having the impact we expect and hope it will. So we want to look at such things as overdose, including overdose deaths. We want to look at their quality of life and other factors, and also importantly, want to look at, does it have any impact on recidivism? So with that, I'll stop and I'll pass it back to Ms. Thrash or whoever's going to take it from here.
Thank you, Dr. Campbell, for that overview. That is a great expansion overview of MOUD, of what we're doing in our institutions, which is very much needed and valuable to the offenders and the population that we serve as they are releasing back into their local communities. So at this time, I will have our team to advise if we have any questions or any comments in the chat pertaining to your presentation. Guy Buckner, do we have any questions at this time?
Hey, good morning, everybody. For everybody streaming through the YouTube, please post your comments in the YouTube chat as I'm checking them. Dr. Campbell, we did have one question so far. Individual was asking where, or if possible, could they get a copy of that map presented?
Yes, sir.
Sure.
So that is a map provided by NC Fit, but I'll certainly find out if there's a link. You certainly can go to, UNC Fit for folks that aren't tracking, is part of the UNC School of Medicine, actually the family medicine program. So that may be available on the website, but I will also talk and see, and we can certainly provide that link to you guys.
Thank you, sir. And does anybody else have any questions? Like I said, please feel free to post it in the YouTube link. I'm checking it live as we speak.
Hey, one thing I did want to add, Dr. Campbell talked about the Narcan that we are providing to all releasing individuals. That's part of the collaboration. We've funded that, but we have also received funding from the Department of Commerce to fund that as well. So again, that's part of those collaborations across the state with our other agencies to help out in this initiative.
Okay. Guy, do you see anything in the chat?
At this time, there's no other questions. No, ma'am.
Okay, thank you. Thank you, Dr. Campbell and Ms. Young for presenting. I know you will stay on if in the event that we have additional questions that may arise in the chat as we move forward with the meeting. So at this particular time, we will move forward with the agenda, and we now have an update about our the pilot program that we're offering in our institution. It is just beginning, and Dr. Brooke Wheeler, who is our Senior Director of Education and Programs, will share at this time and give some information as to what is happening with our peer support program. Dr. Wheeler?
Good morning, everyone. It's great to be here at the State Reentry Council Collaborative meeting. This is something I'm looking forward to being much more involved in as we move forward. I am the Senior Director for Education and Program Services with the Department of Adult Correction, and we are so very excited about starting a peer support specialist program in our institutions. So I'm just going to tell you a little bit about the program itself, what a peer support specialist does, and how that will work inside our institutions to support people who are living in recovery. And also the North Carolina the peer support specialist program is not unique to inside institutions. This is actually a growing career opportunity in the labor market. However, this is the first time it will have been offered inside correctional institutions in North Carolina. So North Carolina certified peer support specialists are people who are living in recovery from mental illness and or substance use disorder, who support others who can benefit from their experiences. They've met North Carolina eligibility requirements, they've completed rigorous training, and are certified through a state application process. This is a recovery-oriented, evidence-based program, and again, is a growing career opportunity in the labor market. This training covers topics such as roles and responsibilities of peer support specialists, how to work with a team, how to resolve conflict, and how to adhere to ethics and agency standards. Recertification is required biannually along with additional continued education, and there will be even more education provided inside institutions as to how this actually is implemented inside of correctional institutions. Training will also need to be provided to correctional officers and staff inside the institutions to help them understand and support the peer support specialists. This training and certification has been provided through the Education Services section of the North Carolina Department of Adult Correction in collaboration with the Behavioral Health section of DAC. Also in collaboration with the Department of Health and Human Services and Campbell University. We've also begun to provide this training through some other college partners as well so that we can expand this program, because that is our goal. We've created a job for peer support specialists who are currently incarcerated to support their peers inside the institutions. We are almost ready to begin a pilot program at Granville Correctional Institution with 4 certified peer support specialists. This is in implementation mode. There is another pilot group of 12 peer support specialists who are serving as peer support specialists in a mental health setting as well. Appropriate duties for specialists include meeting with peers, modeling skills, and assisting peers in the following areas: compliance with treatment goals, daily decision-making and problem-solving, accessing resources, effectively communicating needs, knowledge and compliance with rules and policies, modeling and encouraging healthy relationships with others, new coping skills, demonstrating coping and self-help skills with peers, for peers, creating goals and developing plans to achieve goals. This is a skill that is needed for most people who are incarcerated, and certainly this will be helpful for this population. This may include, but is not limited to, goals and plans that may be related to education, rehabilitation, reentry, and/or mental health. They may also lead appropriate programming, which may include academic tutoring, cognitive behavioral training, and other things that are yet to be determined. Our expectation is that we will exponentially increase the number of certified peer support specialists in the Department of Adult Correction over time, and relatively quickly is our goal. And the number of institutions where we offer this peer support to those in our custody as well is expected to increase drastically. We look forward to sharing more, but I can tell you that our goal is not just to implement this program inside the institutions, but also that it lead to a pathway for these certified peer support specialists to, of course, complete the education, serve in this role while they are incarcerated for their peer incarcerated fellows. Also, though, it could lead to work release opportunities, and then ideally to a sustaining wage job once they are released into the community. As again, this is a growing field in the community. So we're very, very excited about this opportunity for many reasons, but not the least of which is to really include those who are incarcerated, who are working in this field, but also those who are receiving services, and then that will follow them out into the community as well. So very excited about this program and happy to answer any questions if there are any. Thank you.
Thank you, Dr. Wheeler, for sharing that. Guy, do we have any questions in the chat?
I don't see any questions at this time. If anybody does, please post them. But there are, Dr. Wheeler, a few people saying, thank you so much for what your group is doing. It's, wonderful news, and this is great stuff. So some applause to you and the organization, they're saying. So does anybody have any questions? Feel free to post them in there.
Thank you so much. It's definitely a group effort.
Yes, most definitely. We've been having a lot of ask and requests and asking when we were going to expand or even touch on the peer support programming and offering that for our population and those in the community. And as you can see, we are expanding the reentry work. We're providing support for those who are in recovery, not just in our institutions, but also looking at when they are being released from going back into their local communities. So we're grateful for the work, and we're going to continue to have boots on the ground to keep this work going. And so at this particular time, since there are no additional questions or public comments, I will have Senior Deputy Secretary Pettigrew to come back and give us some additional highlights on Reentry 2030.
Yes, thank you, Director Thrash. A couple of things, and thank you, Dr. Wheeler and Dr. Campbell. Great stuff we're doing in North Carolina, like I said. So a couple of things that I wanted to mention. We have posted our Reentry 2030 strategic plan on all the tablets for our incarcerated population. So they can see the strategic plan, all the strategies, all the progress. We also plan to put the progress report when we get that on the tablets as well. Also, and speaking about the peer support specialist job that we have created, we have a catalog now that is on our public facing website. It's also on the incarcerated population tablets. They can go to it and see what every uh, facility, what programs are available, what jobs are available, and what services. And those peer support specialist positions, if they're at a particular facility, they will eventually be posted on that catalog as well. The public can see that catalog as well. It's on our public facing website, so friends and family and those interested can review that as well. And that is one of our strategies we had for Reentry 2030. So we're very excited about that. Finally, I wanted to mention the one thing about what we're trying to do. We firmly believe reentry begins day one somebody comes into incarceration. And we want to improve and provide pathways and room for individuals to grow and build their skills out, and so they can be prepared for reentry. However, in order to do that, it all comes down to one thing: staffing. We are still doing everything we can to improve our staffing, and we have seen some improvement in 2025. We have positive number of hires versus those who have left, but we have so much more work to do. I just encourage this community and stakeholder community in reentry who wants us to do these great things, and we want to do them, but we need to improve our staffing, and we're looking at all strategies just like this peer support specialist. We know our incarcerated population has so much talent, and we can give them purpose and help them build their skills while they're in the population doing all the work. But please encourage those around you. DAC is a great place to have a career and come to work for us so we can do these great things we have in the strategic plan. So I would encourage everybody to do that. I also say this all the time, and I just want to keep repeating this. If you are one of those who have been formerly incarcerated and have turned your life around and you're paying it forward and you're listening to this, please reach out to those staff that helped you on your journey. Just let them know how much you mean to them on your journey. It helps us retain the good staff that we have, and we appreciate that if you would do that as well. So again, I just want to give you those updates with Reentry 2030. As I said, we have a lot to be thankful for, and we are really moving things forward here in North Carolina. And 2026 is going to be even better. So Letitia, I will turn it back over to you. See if we have any questions. And I think we have, Letitia, you have some information about 2026, maybe in April, right?
Yes, I sure do. Thank you, Senior Deputy Secretary Pettigrew. I'm excited always of the reentry work that we do in adult correction and in our local communities across the state. But I do want to share with you that we do have our 2026 Rehabilitation and Reentry conference that will be coming up in April. And many of you who are on this meeting probably have attended our conference, and we have a lot of great speakers and great workshops and sessions that you can glean from. And we look forward to having even much greater impact in 2026. For this year, 2025, we did have over 650 attendees. Forward to sharing that our conference will be again here in Raleigh, North Carolina, at the Hilton Raleigh North Hills, the same location that we had it this past year. So save the date, mark your calendar, because we're going to continue to shape North Carolina's future with Reentry 2030. That is our theme for this year. We will be adding additional information as it relates to registration, sponsorship, being a vendor, and how you can be able to book your accommodations. So please pay attention to our website. If you need additional information, you can contact Guy Buckner, and his information is at the bottom of the flyer that you see. So we're excited about the conference. We're still in the planning stages, but we know that it's going to be a great time, and we hope that you mark your calendars and plan to attend and be a part. Additionally, we had a huge impact for our reentry simulations across the state. We did a lot of reentry simulations for colleges, universities, local communities, our local reentry council. We did simulations with our offender population in our institutions and even with our adult correction staff, just so we can make sure we bring awareness and education as to what it looks like and how we can prepare our offender population for returning home. So I will allow Guy Buckner, who has been doing a phenomenal job traveling across the state, making sure that he showcase our reentry simulations so that we can pull more resources in, pull more people in to be a part in how we can support our justice involved population. So Guy, I will give you an opportunity to share and highlight our the impact in 2025 and what we need to look for in the planning for 2026.
Thanks so much, Ms. Thrash. Again, good morning, everybody. Most of the people who are online have probably done a simulation with us or helped volunteer. And first and foremost, I just want to say thank you to each and every one who's helped out, and whether it be volunteer, participate, organize these simulations. For the 2025, we are slated to do right at 48 reentry simulations across the state of North Carolina, from the mountains to the ocean. And it has truly been a privilege to be able to go across and do all these simulations, working within our facilities, both the male and female facilities, getting to interact with those guys and girls, and you show them resources and availabilities of things that they maybe didn't consider prior to getting released, and be able to help them with those resources has been great. And then getting into the community, be able to, meet and greet, organize, and, build these collaborations and these partnerships has been outstanding. And even within our schools, going to these universities, we've done one at ECU, we've done one at UNC, we've done ones at Pembroke. And again, working with the students, seeing them wanting to, get into this field, see there's a passion for reentry is truly an eye opener. But personally, I believe we did a great job in 2025, but I think we still have room to grow in 2026 as far as getting more simulations out there, building more partnerships, getting the communication out there. So while 48 simulations was great for 2025, I would like to push even more. So if you know somebody who's interested in working together, as far as hosting a simulation, please reach out to me. Please share my contact information. If you need my contact information, it's guy.buckner@dac.nc.gov. And we definitely want to make sure, we push even stronger for 2026 in regards to getting these simulations out there. So thank you so much, Ms. Thrash. And if anybody does have any questions, feel free to put it in the YouTube chat.
Thank you, Guy, for sharing that. We know that we're going to probably more than likely exceed the 48 simulations that you did this year. We've already had people emailing and asking to schedule a simulation for 2026, and we haven't even got out of 2025. So as you see, it has made great impact, and we're definitely glad that it's been valuable for our population who was incarcerated. We've had a lot of survey feedback from them that has shared a lot of great things and ways that they're going to change the dynamics of how they participate in their reentry planning before they go home. So we're glad that we're able to share and educate and aware and bring awareness, to our incarcerated population and to the justice involved population, and just to those of us with people who want to know how they can make an impact and provide support services for justice involved individuals. So at this time, I will double check with Guy to find out if we have any comments or any questions. Does anybody have any questions or comments of Dr. Campbell from his MOUD expansion presentation or Dr. Wheeler from the peer support pilot program.
There is one question that went back to Mr. Pettigrew. I don't want to skip over it. It says, how many prisons will the program ultimately expand to?
Say that again, Guy.
The question, I believe it was referenced to you, sir. It says, how many prisons will the program ultimately expand to?
I don't know what program they're referring to, but I will say Reentry 2030 covers all of our 55 facilities. We release from all of them. One thing that we do have is the designated reentry facilities. And that program, we were at 24. We are adding a new facility who's doing some outstanding work already, and that's Nash Correctional Institution. So we'll be at 25. Nash does a lot of great work. They have 2 of our correctional enterprise plants, and they have the field minister program. And speaking of our talent in our incarcerated population, our field minister program is a great program that we've collaborated with Judson College to provide a 4-year pastoral education degree. And once they graduate, we deploy them to facilities across the state where we also train them to provide programming, Thinking for a Change, our cognitive behavior programming, and father accountability. And they go to these facilities and teach those programs alongside staff. They also provide one-on-one counseling for those that want that, and they are also involved in our faith-based activities. It is a great program. It's an example of utilizing and giving our incarcerated population a chance to increase their skill set, get a good education that could be transferable in the community, and also providing them job opportunities in our facilities. Recently, in the last couple of years, we have transitioned over to a female field minister program and to a 4-year degree program. And in, I think, 2027, and correct me if I'm wrong, Dr. Wheeler, we will graduate that group and deploy those ladies to our female facilities to do similar things that the male facilities, male field ministers are doing. So it's a great program that we have across the state. And in our Reentry 2030 strategic plan, we are increasing the designated reentry facilities to all facilities, and we are mapping that out now for the next 4 years. And you may ask, what's the difference on a designated reentry facility? Well, we have a program in each of these facilities called R-STEP. It's where incarcerated individuals will work with their case manager, and a probation officer comes in at 9 months and starts working with them 9 months prior to release. They work as a group to have group meetings, bringing in different things, have resource fair, and they work on their individual reentry plan. Usually it's this county that the facility's in that they're going home to, or surrounding counties that they will work with. And so this is a great program that we've run for 3 or 4 years, and it's really making a difference in those incarcerated populations' lives. And as we said, we are going to make sure that everyone will be available or have the opportunity to be part of that program once we expand it to all 55 facilities. So I hope that answered their question. Guy, do you have any more?
That was some great feedback, sir. Also with the peer support, expansion on that. Dr. Wheeler, can you elaborate possibly how big it will go? I guess they're referring to that question as well too.
Yes, of course. So we do, like I said, anticipate great success with this first pilot. And once we complete the pilot, I would say we'd probably give it maybe 6 months to see how that goes, collect some data, that kind of thing, proof of concept. And then we'll expand. I mean, I think the goal would be, and now Mr. Pettigrew, please correct me if I'm wrong. But I think the goal would be eventually to be able to have field ministers and or peer support specialists at every institution to be able to support their peers in a very meaningful way with credible messengers able to do that. And I think it's important to say too that we learned a lot of lessons from the field minister program. We learned about how to prevent burnout, some things that we need to do to prevent burnout. These are very intensive therapy support positions for the incarcerated people, and they don't get to go home at 5 o'clock like we do. And so, we learned some lessons about how to prevent burnout, how to communicate with staff, how to really create a process that will be beneficial. And so we want to move this along quickly, but we want to do it well as well. So that may mean a slower rollout than we'd like, but we want to make sure we do it right, if that makes sense.
Awesome. Thank you for answering that question, Dr. Willer. Guy, do we have any other questions before I transition to our next presentation?
I'm currently scrolling through. I don't see any more at this time, but I'm gonna go back and double check and make sure I didn't miss any as well too. So
Okay.
if we
Thank
go ahead
you
and
so
proceed, we can.
Thank you. So at this time, I will present, we have Anne Marie Webb with North Carolina DHHS Peer Support Program Manager. And as many of you probably have heard that adult correction work along with DHHS on several initiatives. And so we're glad to hear that they have a peer support program in their mental health and substance use system, which of course will help those who are releasing back to their local communities. And so we have Anne Marie. I will turn that over to begin to present at this time.
Hi, everyone. I hope everyone is having a great day before Thanksgiving. So I am Anne Marie. I'm the Peer Support Program Manager over at DMHDD SUS. And so I am actually the first person who has really been in this position. I've been here for about 3 years, a little over 3 years now. And so what I do is I work with the contracting for all peer support programs, as well as all policies, procedures, and the North Carolina Certified Peer Support Specialist Group, who is the individuals who actually certify them. But we work on all the policies, we handle all the ethics complaints, things like that. Let me see if I can share my screen. Okay, hopefully everybody can see that now. My computer does not like me. It is the day before Thanksgiving and it's trying to take a day off.
I just want to let you know it does look good. We can see it. Thanks so much.
Okay, thank you guys. And this is the big little cat that always insists on being in everything. Okay, so today we're going to do an overview of what the North Carolina Certified Peer Support Program is, how it's evidence-based in the community, as well as what it'll look like kind of like in DAC, the certification process itself, which will be just a little bit different for DAC facilities, but it'll still be pretty much the same. So I'll kind of highlight those differences. And then workforce initiatives that we're continuing in the peer support world. So entirely, our program is probably going to change through 2029. We're working to create a more robust training and things like that through that time period. So in North Carolina, an individual has to have the lived experience of either mental health or substance use, or both, to be a certified peer support specialist. It does not have to be an actual diagnosis. They just have to know it. However, we understand that during life, there are things that could cause trauma, such as grief and things like that. If it's not, and over an extended period of time, we do not count it as a mental health child concern. So they have to have lived experience, again, and they have to be 18 months into recovery. So we recently changed that time period from 1 year to 18 months as we were meeting with different peer supports throughout the state. we realized that the 1 year just really isn't enough recovery. And then we started meeting with other states. We met with 16 states throughout the United States. And they all said that they actually have about 2 years in recovery. So we decided to kind of do a middle ground so it wasn't as big of a change. They have to have a high school diploma, GED, certificate of completion, any equivalent. So like whether they're homeschooled, anything like that. They need to be willing to share their own recovery story. This is huge in the peer support world. It's how you help individuals and how they know that you have actually lived the same path as them, although it might not be the same recovery path. A lot of the stories will be similar. They have to complete certification training of their choice. I'll explain that in a little bit. We kind of have 2 paths to certification right now. 20 additional hours of mental health or substance use, 2 letters of reference. So the first time an individual becomes certified, we like those letters of reference to be from individuals who know about their recovery path. After that, it can be from employers, anything like that, showing that, hey, I know that this person's still in recovery. I know that they're still doing the version, whether it's harm reduction or whatever the individual chooses, and they're doing very well right now. Understand that every person has their own unique path. Recovery is not linear. That is huge. Everyone needs to know that just because it worked for you doesn't mean it's going to work for everyone. And the peer support specialist has to truly know this in order to be able to help everyone in the community. They work as a supportive agent. They do not force anyone to do anything. They do not force any type of counseling or anything on the individual. It's all about, hey, I'm here to support you. I'm here to help you teach how to advocate for yourself. And I'm here to help you meet your goals. But this is on the individual being served and not the peer support. So the big thing that they're doing currently is they assist the clinical staff in truly understanding the individuals that they're helping, where they are, what their needs are, as well as they help lower overall costs for behavioral health services. And over a 2-year period, they drastically lower the risk of hospitalization and inpatient lengths of stay. So they kind of do this through a definite mutual power or mutual empowerment and respect. I'm telling y'all, it's the 2-day or 3-day work week. Meeting the individual exactly where they are. So this can be active addiction. This could be a year in recovery. This could be an individual who's 35 years in recovery and lost their spouse, and now they are beginning to feel like they need someone to help them stay on the right track during this. It can be anywhere. It does not matter. A peer support specialist is there to help. And they help them kind of learn everything about their own system. So that is the transportation services, clinical services, community supports, who to contact for housing, how to get a job, how to do a job interview. And then they assist the individual in finding support and building their own community. So I spent, prior to this job, 12 years working in the Justice Department with individuals with mental health and substance use primarily. And the biggest thing that we would talk to the individuals about was, hey, I'm doing great here, but I know as soon as I go home, things are going to get rough again. So the peer support's one of their biggest things that they do is helping them build what they call a healthy community. So people who are going to be there to support the individual and provide them that. They can also assist individuals in crisis and helping them find resources to support them during that time. So we do like to go through the Medicaid definition and SAMHSA's best practices based on what a CPS is meant to do and what they're not meant to do. And we always bring this up. I know this is going to look different in DAC, but it will look similar in the reentry programs. Because when we were interviewing we interviewed over 200 certified peer support specialists. And when we did that, we found out that they were doing janitorial duties regularly. They were regularly doing administrative duties, not for themselves, but for others in the office, as well as they were helping with counseling sessions. And by that, I mean that they were actually leading the counseling sessions, not being there as a supportive agent. And those are not things that a peer support specialist should be doing. So they can provide transportation services, but it's meant to be like, hey, this is the bus route. You need to go over to Walmart today. Let's figure out the bus route and take that bus with the individual. They cannot provide childcare activities. They also cannot provide services to the children, spouses, or other family members. That is a huge boundary, not only for the individual being served, but also for the peer support specialist to be kind of stuck in the middle. And they do not develop the person-centered plan. They can help the individual come up with their own goals prior to meeting with the QP or the LCSW, but they cannot sign off on it and they do not develop it themselves. So peer support and evidence-based practices. So we looked at a lot of different states, but this is some of the data that we were able to get when talking to states. So some of this data is from New York, Tennessee, Arkansas, Georgia, and several others. They have shown a decrease in crisis and recovery costs. They lower hospitalization rate. So studies show that between a 32 to 56% reduction for individuals who have a peer support specialist, the lower re-hospitalization rate. So it was a 3.4% rate lowered over longer lengths of time between hospitalizations. So that was like looking at an individual who had a crisis, came out of the crisis, 90 days later, they may be back in for another crisis. So individuals who had a peer support, instead of it being the 90 days, it might be 180, it might be 365 days, things like that. So they lower the length of time. And if peer support actually is staffed into a crisis program, or at the beginning of when a crisis program might start. So like, hey, this individual is starting to go towards a crisis, let's bring in a peer support. It actually shows that it can lower $2,000 decrease in the additional services needed to support the individual. So in North Carolina, the Department of Health and Human Services conducted a study. I believe this was in like 2019, 2020 area. And the CPSS in North Carolina were very effective. They showed a $775 value, so it lowered the amount of cost, and 65% of individuals exceeded the cost. Most individuals averaged 77 hours of peer support throughout their time of having a peer support, and then they stated that they began to feel better about working on their journey by themselves. And the NCCPSS helped individuals gain employment, maintain their positions, maintain housing, everything like that. We know it comes with a job, you're able to get the housing and things that you need. So in North Carolina, we are working on expanding high quality peer support services. As I stated, we started this by reaching out to providers, peer support specialists, and we built everything that we are doing off of what was stated by the individuals actively working in the field. That was what was the most logical to me was, hey, they're the ones doing the job. What do we need to do to support them? So these are some of the initiatives, which I'm going to go into a little bit more in depth. But first, I'm going to cover the certification. So right now, currently, we just launched a new standardized curriculum. It has been a very large baby of ours for about a year and a half. And 16 certified peer support specialists built this curriculum. I'll go a little bit more in depth of what it is in just a minute. But this is the journey that an individual can take. So the individual has 18 months in recovery. They complete their 20 additional hours of training, which is all free. There is a bunch of training on the peer support program webpage that maxes over the 20 hours, and it is completely free for the individual to take. And then they send in their application, their letters of reference to the program staff, and they get put into a 20-hour free online certification. This is, and you'll get a glimpse of it in a minute, very self-paced, very like in-depth. It provides scenarios, it provides podcasts, it provides one-on-one videos with some of the information that the peer supports who built it decided that should be input in it. So it shows conversations that can happen real world, all of it. After the individual completes that, they sign up for the 40-hour in-person course. Right now, it is completely free because we have some additional funding that was left over from building the program. Afterwards, it is going to stay a low-cost program. So it is very much kind of like a CIT training, very hands-on. Then they will take an exam. This has not launched yet. It will launch in January. We are working on building a study guide. So individuals can not only take the course, but also have the study guide to help them understand the course a little bit more and prepare for the exam. And then they would submit their application to achieve their full CPSS certification. There is another pathway that I did not highlight in this. We have about 10 50-hour in-person courses that are certified throughout the state, and they can pay to take those courses. They average between $125 and $400 to take. That is part of the reason that we wanted to make sure that this was low cost. So again, the peer support specialist training, it's 20 hours. It has multiple learning pathways. It is written at a 6th grade reading level, and it is 40-hour in person, again, written at a 6th grade reading level. We very much wanted this to kind of look like a really high quality CIT training, like, hey, here's your policy, here's kind of like what it would look like in the community. This is what you need to know about trauma informed, and this is how you can kind of use a little bit of it in the community and recognize what's going on. And it is currently, as I stated, free to anyone who meets the requirements. So the online consists of 9 sections. So we have the worldview. So we're looking, this peer support is an international program, and it's being done well in several different countries. And so we kind of want to provide the worldview of it, the values and principles of peer support, self-care, wellness. This is not only for the individual that they are working with, but this is also about the peer support. Burnout is real. We know burnout is real in any job, and we want to help them better understand and prepare themselves if they feel that the burnout is coming. Role, purpose, and scope, the history of the recovery movement, and we cover everything. Nothing is left untouched to make sure that they fully understand, like, hey, this is where we were 60 years ago, and this is where we are now. Ethics and boundaries, which is huge. And then the communication language. So this is peer-to-peer engagement, storytelling, active listening, everything. Legal systems and resources. We do have a diversity, equity, inclusion, but it's more of a recovery in different communities, because we know that all communities are going to be different throughout based on their culture and their experiences and things like that. So this is the first page of the course when you get logged in. It is going to look a little weird on a computer. I have been in it, I've played with it, but that is because it is also accessible by a smartphone. So if an individual has a smartphone, they are able to access this and take all of it. And then it's going to have model conversations. So in these conversations, these are conversations that the peer supports wrote and came up with through their lived experience as a peer support. And they were able to say, like, hey, this is something that I didn't know when I first came in. Maybe we should kind of role play it, model it, and show how it should go. It has audio modality. So basically, if there is a writing portion, because I know that I don't learn just by reading. So if there is a portion such as that, it can be read to you. So that is what this is down here. So it shows that it's like kind of like this area where you're reading, and then right here you can play the button to have all of it read to you. And that is throughout the entire course. It also has closed captioning, and the ability, we are working on the ability for the closed captioning to do real life translation into Spanish. It has learner-driven choice activities, so individuals have to stay engaged. We also, as I said, we put in podcasts, we have TED Talks, we have everything that we could think of to really kind of say, like, hey, this isn't just going to happen once, this could happen multiple times. And then we to the in-person. So this is like one of our biggest different areas compared to our older 50-hour courses. They were all just 9. We now have 13 modules. We're going to recover some of the other modules, and then we're going to add some in. And some of those are harm reduction, advocacy and reducing prejudice and discrimination, as well as stigma, crisis response, trauma response approaches. So we added in things that we know that an individual at least needs to touch on. We're not saying that they're going to come out and be perfect and know how to fully understand a trauma response or fully understand harm reduction. That wasn't the purpose. It was just to give them a basic background of, hey, this is what it could look like. This is what you need to know. So our new thing, one of our new things that we are launching is that we have the peer support technical assistance. So this is through UNC School of Social Work, who is actually owns our North Carolina Certified Peer Support Specialist program. And they are working with not only the peers, but also the individuals who want to hire peers. And they're teaching them like, hey, this is what a job description should look like. This is what a peer support can do. This is how to write a good job description. This is how to support a peer support and supervise them. This is actively being done. However, there will be a portal for this in April, so that individuals can kind of submit like, hey, I need a little bit of help understanding like I've had this happen with my peer support. Can you help me? And they will be able to do that. So these are the initiatives that we actively have in progress. And we have the partnering with the Division of Mental Health Benefits. So we are working with Medicaid on updating the peer support 8G Medicaid definition, as well as the state plan definition. We want to make sure that they fully function for all peer programs and they can be sustainable for all peer programs. And so that is something that we are working on. It has had minor updates since it was first launched in 2019, but it hasn't had actual updates for how peer support is functioning in North Carolina. So that's what we're working on. We are going to be developing, and I think it's already posted if I looked at the webpage the other day and I saw it correctly, a LinkedIn resource. So this is for peer supports to kind of get in with providers and say like, hey, here's my resume. Like, I think I'd be a good fit. It also helps them with building their resume. And if a peer support signs up for it and they live in like the Morganton area and somebody submits a job for Morganton, we can evenly immediately send it over and say, hey, this job was posted. If you're looking for a job, here you go. We also started the peer-to-peer mentoring app through Connections. So what this is any peer in the state of North Carolina can reach out and talk to any other peer to provide that like support to each other. And so that we can kind of lower the rate of burnout. It also does after hours peer support for individuals if there is a provider that does not have 24-hour service. So we are actively working on the creation of an IDD and TBI curriculum. We are hoping to launch this in 2026. And so this will be for individuals who have lived experience with IDD or a TBI or both, able to go out and provide peer mentoring services to individuals. So this will look different. It's not about recovery. It's about providing the support. It's not about working with the families. It's about saying, hey, like you have this ability to do this for yourself. Like, let's give you the resources that you need to fully get there. It's the creation of the specialty job training. So if anyone is on our listserv at DMH, we recently sent out the RFA for justice-involved populations in crisis. We're also going to be working on more, so like hospital, working with maternal mothers and getting them through their recovery while pregnant, things like that. We are hoping to develop like a different culture, like a more in-depth of different cultures in the community, because we know that recovery and stigma is very different based on different cultures. And so we want to be able to provide that support to the peer support and say like, hey, this is what kind of the roadblocks you might hit when you go into the different areas. We are also going to be developing a peer supervisor training. And that is active right now. I should have moved this and I forgot. They're actively working on this right now. And it is being developed by clinical partners as well as peer supports who are supervisors to better prepare an individual to supervise a peer. And we, as I said, will be putting the technical assistance on the webpage by April. So I wanted to like kind of add in like what it'll look a little bit different for DAC itself is we do have trainers in the areas. We now have 21 trainers throughout the state, and they can kind of go out and be like, hey, I'm able to have this training for everyone. If anybody needs to want this training, the program is Moodle. So if the individuals have the ability to have Moodle, they can do that, as well as UNC has stated that, hey, like we don't need everyone to give us their email address. One person in the facility can submit the application for individuals, and then prior to the release, they can just tell us like, hey, this is going to be the person's email from now on. So we are very much coming up with different policies and procedures to kind of work with DAC and be able to support them in getting the peer supports into the prisons, the jails, and the communities upon their release. Individuals can also be certified while in DAC. I think we have 8 that took the course and might be certified, I believe. And so that is something that's very big. So when those individuals come out, they will be certified and be able to go out and get a job as potentially like a reentry specialist, which would be great. So do we have any questions? And this is my email if anybody needs me.
Thank you, Anne Marie. That was an awesome presentation of giving us more details on the peer support in mental health and substance use system, what DHHS is providing. A lot of great valuable information. Guy, are there any questions for Anne Marie in the chat?
At this time, I do not see any questions. If anybody does have any questions, feel free to put them in the chat for us, though. But no questions at this time.
Yeah.
Okay, great. Thank you, Anne Marie. We'll hang tight while we are seeing if any public comments. And while we're waiting on that, I will allow Senior Deputy Secretary Pettigrew to share some closing remarks or feedback that he may want to share at this time before we check again to see if the attendees have any questions or public comments, and then we will prepare to close out.
Thank you, Director Thrash. First of all, I just want to thank Dr. Campbell and Anne Marie Webb for presenting today. Great information, some great stuff that's happening in North Carolina. DHHS is a wonderful partner with us on this journey and is doing some great work, especially with the peer support specialist training. So we appreciate, Anne Marie, for you being on, and Dr. Campbell, of course, all the work you are doing. I just want to remind everybody, we have everything on our website. Please go to that and look at all the Statewide Reentry Council Collaborative information, also the Reentry 2030 information. You can also email us if you have questions. I know that happens to me in meetings. I'm like, man, I should have asked this question. You can send it to us. We'll try to answer as best we can. Not, we'll try to find the answer for you. But we really appreciate everybody being on today. As you can see, as I said at the beginning, North Carolina has a lot to be thankful for, especially in the journey of reentry. And you heard from our secretary, she is all about this mission. Our governor's office is, and all our state agencies are engaged and involved as well. Guy, do we have some questions?
We have one public question / comment. I apologize, I had it ready. It states, will DAC eventually use person-centered language?
Great question. And that is vitally important. I will say our secretary emphasizes, and everybody in our senior leadership, we are in the people business. We're about changing lives and giving people that second chance. And we understand language is an important part of that. We are having internal discussions as we speak. In fact, we are planning to survey our incarcerated population on person-centered language as well here on our tablets soon. And we are continuing to have those conversations. What's vitally important to us is, and for everybody to understand, we always preach and teach in all our trainings with all our staff that we will respect and provide and have dignity for all those that are in our care. And we are not going to demean anybody in what in our communications. So we are looking at that, and as you can say, that is a process. So more to come in that realm.
At this time, I don't see any other questions in the chat.
Okay, so we've had a wonderful fourth quarter SRCC meeting. Much appreciation to all of our presenters, Dr. Campbell, Ms. Young, Dr. Willer, Anne Marie. Much appreciation for sharing all of the great work that you're doing and expanding services and programming for substance use treatment and recovery, so that we could be able to afford these great opportunities to our population. Pretty much at this time, our meeting, our next meeting, just save the date and just pay attention to our website, will be in February. We're still working out details of location and date. And you did receive the next date for our JRC meeting in January. So we hope to see most of you attend that meeting. So at this time, Guy, I just want to ask one more time if there are any questions or public comments in the chat before we conclude.
No more questions, but again, someone did say thank you so much for all your efforts. So
Wonderful. Thank you, and thank you for attending and being a part of these meetings. So I wish everyone a wonderful Thanksgiving. Thank you for 2025 and all of the work and being connected with all that adult correction is doing across the state. And we look forward to seeing you at our next meeting. Thank you and have